Would you want to call the next speaker?
Dr. Himani. Dr. Himani will be talking about long-term changes following the ICL.
Is it Himani? Dr. Sonu Goyal is over?
Dr. Sonu Goyal presented in the beginning.
Oh, okay. Ah. No, it's not fair. Let's see.
A very good afternoon, esteemed judges and my dear colleagues. So I am here to present a very interesting paper on Indian eyes, which is the long-term wall changes following ICL V4C. So what was our research question? We found that Chinese adults had a smaller antechamber angle and antechamber volume as compared to Malaysians and Indians. And also we are totally relying on the data given by the Chinese population or the Western population to assess the wall changes in Indian eyes. So our aim was to assess the wall changes over a period of 1 year following ICL V4C implantation for myopia and astigmatism, and also assess the factors associated with the long-term wall changes. So we did a retrospective observational study for 1 year in 154 eyes from 77 patients and included myopia and astigmatism with all the parameters within normal limit and excluded those with hyperopia, any oculopathology, and patients who had lost to follow-up. So we calculated the pre-op white to white with calipers done by a single observer. The corneal curvature, pachymetry, and antechamber depth were measured with pentacam. The ICL power and size were calculated using the STAR surgical software, and the implantation was done through a 3.2 mm incision by a single surgeon. We assessed the lens vault values using AIOS2025 on day 1 month, 3 months, 6 months, and 1 year. And then we divided them into 3 groups based on the vault values of day 1 in less than 250 microns, 250 to 750 microns, and more than 750 microns. This is how we calculated the ICL size and power with the preoperative data. We did the statistical analysis using the AIOS2025 version software and the following tests. And we found out of 154 eyes, 101 eyes were females and 53 eyes were males, and 148 eyes underwent toric ICL. This was the mean preoperative data which we found. On assessing the mean wall changes, we found a decline, significant decline from the baseline, especially during 3 months and 6 months, which was significant in each visit in each subgroup from the baseline. On assessing the 3 groups, we found a spherical equivalent and anterior chamber depth to be significant in amongst the 3 groups, with 22 eyes in group 1, 120 eyes in group 2, and 12 eyes in group 3. On assessing the group-wise mean vault values, we found a significant increase in the low vault values at 1 month and a decrease in the group 2 and group 3 values. We also found significant correlation of white to white and K1, K2 with the vault decrease. The white to white showed negative correlation. That is, larger the white to white, lower is the vault decrease. And corneal curvature showed positive correlation, which means steeper the cornea, higher is the vault decrease. The BCVA, IOP, and endothelial count had no significance. We also encountered a few complications like cataract in 2 cases, retinal detachment in 1 case, low vault less than 100 microns in 2 cases, high vault more than 1300 microns in 1 case, traumatic ICL subluxation in 1 case, spontaneous toric ICL rotation in 2 cases, and steroid-induced glaucoma in 2 cases. So a similar study done in Chinese eyes shows a wall decline at 6 months, whereas our study, which is the first study in Indian eyes, shows a wall decline in 3 months. And also our vault was like comparatively lower as compared to the Chinese eyes. In the same study, group 1 showed a decrease in Chinese eyes, and our study showed a significant increase in the low vault cases. A meta-analysis study shows no correlation of corneal curvature with the wall decrease, but our study shows a positive correlation with the wall decrease in Indian eyes. So on digging further, we found that steep cornea has low white to white, low antechamber depth, and antechamber volume. So that correlated with our study that steeper cornea has higher reduction in vault values from the baseline. The Chinese eyes had also a fallacy that they used pentacam to measure the lens vault, which causes the underestimation of vault values. But our study used intersegment OCT, which is the gold standard. So to conclude, low vault, especially 150 to 250 microns, increases in vault height at till 1 month, but they tend to remain less than 250 microns at the end of 1 year. And similarly, high vault decreases in vault height till 3 months, but they tend to remain more than 750 microns even after 1 year. So we need to closely monitor both these cases and timely intervene and to prevent complications. And the most important conclusion which I would like to say is that steep cornea has much more significant vault decrease over time. So careful monitoring and preoperative ICL size adjustment is very important. So a few limitations like this was a small subset of eyes in Indian population done in a small, like Eastern India. We need to, do further tests, and prospective analysis of these tests is also important. These are some of my references, and thank you.
Nice paper, because it's very important. There's a very important point she's brought out, that if we all of us start measuring the wall size, we will understand that there is some variation which is occurring, because there are variations in the white to white measure done by the technician, and which is why now UBM measurements have started gaining greater footage, although we don't have those advanced machines in our country. But having said that, in your opinion, like, we realize that if it's a high vault, there's more likelihood of angle getting closed and all that. So is it better to err towards a low vault, because a low vault doesn't get too low? Would you believe that? Supposing there are two white to whites which are a little different. So would you err to a lower vault, or would you err to a higher vault?
So, ma'am, since our study, we had higher number of lower vault as compared to higher vault. So, the 12 eyes of higher vault did not have any increase in IOP in our study. So, higher vault can always be assessed, and also they tend to get lower at 3 months. So, we can wait and watch at least till 3 months if they are not having any other complications.
Yeah.
Did you measure the angles in any of these patients with the higher volts?
No, if she is asking, she's asking you.
Yes, sir.
If there's a high vault, would you do a gonioscopy to know whether the angle is getting narrower and getting
Yes, of course, sir. Yes, sir.
Huh? You are
Yes, sir.
doing-
And still the IOP did not rise?
No, sir. The IOP did not rise.
Central hole.
Because the antechamber depth in those
The
cases
central
were already considerably higher than that of the low vault cases.
Why did not it rise? Because of the central hole?
No, so I think the overall angle pre-op itself is very
No,
big.
they were in that small subset of patients, maybe the
The
angles were
antechamber
widely
depth was
open.
already higher in those
Angles were
subset of
widely
patients.
open, and the measurements were not so off. Measurements were just slightly off, so little higher vault did not matter much. Thank you.
Did the vault size have anything to do with the refractive error of the patient?
No, sir.
High myopes, low myopes?
The spherical equivalent?
Yes.
Yes, sir. The spherical equivalent was significant amongst the three groups. The higher vault group had higher myopic power in their eyes.